Welcome to Acute Care Podcast. This is our episode number 120. And today I'm joined by my co-host, Dr. Josh Chacko. So welcome, Dr. Chacko.
Hi, Swapnil. Good evening.
Good evening. This is our last episode of 2023. So wish all listeners in advance Merry Christmas, Happy Holidays, and also wish you a very Happy New Year for 2024.
Merry Christmas, everyone. Have a good time during the Christmas holidays.
This time, we are going to discuss another landmark randomized controlled trial, which was published in JAMA recently. And the trial is called as NICO trial, which stands for non-invasive airway management of comatose poisoned emergency patients. Now, this trial is interesting because this is probably the first time we had available evidence in the form of randomized controlled trial in the patient population who are comatose secondary to drug overdose. Now, the practice in this particular population where patient comes to ED with acute drug overdose, either secondary to polypharmacy overdose or certain drug overdose, often the practice which has been in the past was you usually use the GCS as a cutoff. And if the GCS is less than 8, where they're considered to be not protecting their airway, and the practice was to consider intubation and then obviously transfer to ICU. Over the period of time, the practices have changed significantly, and people tend to avoid intubation in this subset of population. And giving a more benefit of doubt, people tend to wait and observe to see whether these patients wake up, and usually don't need to jump to intubate these patients early. However, the practices still vary across the globe, and often they are dictated by resources, amount of time the patient spend in ED, and amount of time they need to be observed with a one-to-one nursing. And often these patients sometimes need some interventions such as activated charcoal. They need some imaging in the form of CT brain, or sometimes these patients are not particularly low GCS, but they are agitated and very difficult to manage. And that's why the intubation kind of considered in this subset of patients as an appropriate intervention. And there are a few benefits to be thought about of early intubation, such as preventing the risk of aspiration and subsequently the pneumonia. Now, just to understand the extent of the problem, just in the United States, patients who are admitted with acute poisoning who get intubated each year is more than 20,000 patients. And I think that's a huge number per year to get intubated just for acute drug overdose. Unfortunately, we do not have a data in different subcontinents, but still it's a major problem across the world. I think we are going to see this problem more and more over the period of time as we see increase in psychiatric conditions and prescription of medications such as SSRIs, SNRIs, or benzodiazepines in the community. So this trial has clearly asked the question in order to reduce the knowledge gap of whether these patients will be safe enough to not intubate early and monitor closely in order to avoid either ICU admission, or avoiding early intubation will lead to decrease in mortality. So, Dr. Chacko, can you please walk us through the methodology and the results of this trial, please?
The NICO randomized controlled trial was conducted in 21 centers in France between May 2021 and April 2023. They screened adult patients who are more than 18 years with a reduced level of consciousness, that is GCS of 8 or less, following acute poisoning. They excluded patients who required urgent intubation anyway, such as patients with acute respiratory distress, suspicion of brain injury, seizures, and shock. They also excluded patients who were intoxicated with drugs that may lead to cardiac toxicity, including calcium channel blockers, ACE inhibitors, and intoxication with a single reversible agent such as opioids and benzodiazepines. And they excluded pregnant patients as well. Patients were randomized to withholding of immediate intubation, which was the intervention group, or routine care, which is control group. Randomization was stratified by center. So in the intervention group, intubation was withheld unless there was an emergency indication, which I mentioned previously, including oxygen saturation of less than 90% with supplemental oxygen through nasal prongs, vomiting, systolic blood pressure of less than 90 millimeters of mercury, after a liter of fluid resuscitation. So that was the intervention group. And in the control group, the decision to intubate was left to the judgment of the treating clinician. Patients were closely monitored with oxygen saturation levels, heart rates, respiratory rates, and the GCS for the next 4 hours, or until the level of consciousness improved to 9 or more of GCS. After 4 hours, the period of intervention was considered complete, and further management was carried out according to routine practice based on clinician discretion. Intubation was carried out based on standard guidelines for rapid sequence intubation, which included the administration of a sedative agent such as etominet or ketamine, followed by succinylcholine or rocuronium. Non-invasive ventilation was allowed in patients with hypoxia. How did they calculate the sample size? The composite primary outcome was a hierarchy of endpoints in the order of their clinical importance. First in the hierarchy was death. Second was ICU length of stay. And third was hospital length of stay. So the primary outcome was a composite of all three in their hierarchical order of importance. And the outcome was truncated at 28 days. The authors calculated a sample size of 100 patients in each group, which would provide the study with 98% power to detect a difference in the primary outcome at a two-sided significance level of 5%. And they allowed some patients to be lost to follow-up or lack of consent, and thus 120 patients are planned to be included in each group. What did they find? They enrolled a total of 237 patients who were randomized. 225 were included in the primary analysis. Of these, 116 were in the intervention group and 109 in the control group. They were young patients. The median age was 33 years. 62% were male patients. The median GCS at randomization was 6, with an interquartile range of 3 to 7 in both groups. Alcohol was the most commonly involved toxin at 67%. The intubation rate, as you would expect, was lower in the intervention group. The intubation rate was 16.4% versus 57.8% in the control group. And among the 19 patients intubated in the intervention group, 16 had at least one criterion for emergency intubation. Now, let us look at the primary outcome. As I mentioned, the composite primary outcome of a combination of mortality at 28 days, ICU stay and hospital stay, all truncated at 28 days, was more favorable in the intervention group. The authors used a slightly different statistical technique, which gave them a win ratio. This is by pairing patients in both groups for each day of follow-up. So what they found was the composite primary endpoint was significantly more favor if you withhold intubation rather than if you intubate based on the discretion of the clinician. The win ratio in favor of the intervention arm was 1.85 with a 95% confidence interval of 1.33 to 2.58, p less than 0.001. The results were similar even after stratification by study center. The win ratio favored the intervention group on pre-specified subgroup analysis among patients with a GCS of less than 7. There was no significant difference between groups in patients intoxicated with alcohol, benzodiazepines, gamma hydroxybutyric acid, or gamma butrolactone. Among the individual components of the primary outcome, there was no mortality in either group. The median ICU length of stay, which was second in order of hierarchy, was shorter in the intervention group. Intervention group, the median ICU length of stay was 0 hours versus 24 hours in the control group. The median hospital stay was also shorter in the intervention group, 21.5 hours versus 37 hours. On exploratory analysis, A clinical benefit was observed in the primary composite endpoint among patients who were not intubated compared to those who were. What were the secondary outcomes that they looked at? Fewer patients were admitted to the ICU in the intervention group, that is, if you withhold intubation. 39.7% versus 66.1%. So the majority of patients in the control group were treated in the ICU, while the majority were not admitted to the ICU in the intervention group. As expected, mechanical ventilation was also carried out less often in the intervention group. Adverse events during intubation were less common in the intervention group as well. Among patients who were intubated, the median length of ICU and hospital stay were not significantly different. So once they got intubated, the ICU stay and hospital stay were not significantly different. The risk of adverse events due to intubation were also similar. So the authors concluded that among comatose patients with acute poisoning and a GCS of 8 or less, a strategy of withholding intubation resulted in a lower incidence of the composite primary endpoint of in-hospital mortality, length of stay in ICU, and the hospital length of stay.
Thanks, Dr. Jacko. So I found this study quite fascinating, and this is probably the first and largest randomized controlled trial to date available on this topic. So clearly a very welcome trial on this topic. Now, there are a couple of interesting facts or limitations of the trial before we kind of discuss some of the strengths of the trial. First and foremost, this trial was unblinded. And again, probably it's very impossible to blind the intervention in this particular kind of trial. So all the limitations which are associated with unblinded trial kind of apply to this trial as well. Now, the main interesting limitation, or you can consider as a bit of innovation in this trial, is how they come up with a primary endpoint. And it was considered to be the hierarchical composite outcome of death, length of stay, ICU stay, and hospital stay. And then they come with this innovative approach of win versus lose or a tie. So I guess every time you will have a composite endpoint, the power will be less. And clearly this study is underpowered to detect any difference, particularly with regards to mortality. Now, studying the mortality in this particular patient population with interventions such as intubation, I think it's probably a far-stretched primary outcome. But length of ICU stay is probably the most relevant and important outcome for me, because I guess even if you can say that by not intubating these patients, if you can save 1 day of intensive care stay, that's a huge cost reduction. Another interesting limitation is the use of GCS in this subset of population. Now, we all know initially when Janet and Tistel invented GCS, it was mainly meant for the use in the patient with traumatic brain injury. Now, we extrapolated that to all subset of neurological conditions, and we use GCS quite routinely in patients with stroke or any other neurological problems. And again, using the GCS as a cutoff for intubating patients in this particular cohort of patients with acute drug overdose is probably not the ideal way to do things. And I think this trial again highlights that limitation of using GCS as a hard cutoff for intubation. Sometimes we just need more close observations. Now, the question comes whether these patients can really go to wards. And I think that's something which is will depend on each setting, because in some systems, the ward admissions won't be feasible. In fact, because they won't get nursing ratio 1-to-1. And these patients will need close monitoring. In case they deteriorate, they will need protection of their airway. So I don't think this trial again shows that this will save the ICU admission. Yes, the length of stay might be definitely less if you don't intubate the patient. And I think that's what we commonly observe when the patient comes intubated from emergency department to ICU. We often within 4 to 6 hours, we stop sedation, wake them up, and then extubate. This trial has again proven that intubation is not an intervention without any risk. In fact, it can lead to more harm, such as development of pneumonia or the esophageal intubation or risk of trauma. So clearly, this trial has given us a signal in terms of we shouldn't be intubating all the patients with drug overdose just because their GCS is less than 8. So clearly challenged the dogma in some settings that where the practice is still prevalent. And I highlighted if we know which toxins patient has consumed, then we can make a better choices in terms of whether we should secure the airway early or not. And the toxins that you mentioned in this trial predominantly were alcohol, benzodiazepines, GHB, which are very short acting and usually don't threaten the airway. On the contrary, if you have a patient with a toxins such as calcium channel blockers or beta blockers, and then the patients are extremely unwell with the hemodynamic instability, I guess in that case, you better protect the airway when they have issues with a low conscious state at the same time. So that's my initial thoughts. What's your thoughts, Dr. Chakko?
As you rightly pointed out, although the GCS was introduced by Janet and Teasdale in 1970 to evaluate patients with acute brain injury, it was extrapolated as a guide for deciding upon the airway management of any type of altered sensorium, particularly among the toxidromes. So that was considered to be the right way to go. But then we all felt over the years that in toxins, in acute poisonings, we probably can wait for a little while, especially if the toxin involved is short acting. And if there is a reasonable prospect that the patient might wake up in the next several hours without endangering the airways, you could withhold intubation till such time. And this study, first randomized controlled trial that compared these two strategies and came up with a very, very clear finding that you can indeed afford to wait for a few hours before you decide on intubation and not rush into intubation straight away based on the GCSFH alone. And the study really busted the less than 8 intubate dogma in that regard. So that's been pretty revealing. And I think it's a good pointer, a good guide for clinicians, particularly in the emergency department, which would allow them to rethink their practice of intubating patients who present with altered sensorium due to toxins. Of course, they excluded several toxins, including cardiac drugs that might cause cardiac toxicity, which is reasonable. In such situations, of course, if there is any hemodynamic instability or a prospect of hemodynamic instability, you would prefer to intubate them early. And apart from the limitations that you mentioned, there are a couple of other concerns as well. You need to look at what sort of toxin you're dealing with, most importantly. And in this particular study, their patient cohort was mostly alcohol, benzodiazepines, gamma hydroxybutyric acid, gamma butyrolactone, and so on. But especially in Indian ICUs, there are many toxins which might need a different type of airway management, a more early intubation, particularly in, say, patients with organophosphorus toxicity, who might actually worsen with time. Their neuromuscular weakness might worsen over time. You may need to consider early intubation in such patients. And you also mentioned about ward care. I think I firmly believe in most Indian ICUs, patients who are in altered sensorium due to any toxin would not really be handled in the ward, purely because most of the hospitals do not have the facility or the type of nursing care to look after these patients. And it is almost always that they are managed in an ICU setting. So you need to tailor the approach based on the type of toxins that your patients may present with before you decide on whether to manage them in the ICU or in the ward. But overall, I think this study lends further strength to the commonly held view that you need not rush into intubation straight away in toxidromes, particularly in cases where you're fairly sure it's a short-acting agent. You might wait for a few hours. Look at the level of sensorium closely. It might be beneficial to wait for a few hours rather than rush into intubation. One of the other interesting things that I found is, although you do early intubation, presumably to protect the airway, in this particular study, the risk of pneumonia was higher, paradoxically, among patients who underwent intubation early.
Thanks, Dr. Chakko. So I guess extrapolating the results of this trial can be still quite challenging because sometimes the pre-hospital setting, the paramedics will have their own kind of protocols. And often these protocols have to be kind of standardized across the board. And I think that's why the GCS cutoff was introduced initially. Hopefully, this trial will change those protocols and there won't be any rush to intubate these patients, especially when the information is very clear. However, what to do when there is either polypharmacy overdose or when the information is not available, as you rightly mentioned, the OP poisoning, for example. In those kind of subset of patients, it will be still quite challenging to practice what this trial has shown. So that's the one thing. And I think that's why external validity of this trial is slightly questionable, because every country or every area will deal with different sort of toxins or toxidromes in their emergency departments. I think signal is very clear, and we have already adopted these practices to some extent in majority of the settings where there's no rush to intubate the patients, especially when the drug overdose is secondary to short-acting drugs, including alcohol or GHB. And it's just that wait and watch approach is probably the best approach in that particular cohort of population. So as I said, it won't probably change my practice, but it will help definitely to many emergency department to reflect on their practices. And if they are doing early intubations, they might change their practices in the future. So that's the end of our today's podcast. We'll be back probably after the new year now. So stay safe, enjoy your holidays, and wish you a very happy Christmas and New Year once again.
Merry Christmas and Happy New Year to everyone. See you in the new year. Bye for now.
Thanks for listening to eCrit Care Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCrit Care Podcast.